Exertional rhabdomyolysis in horses. Welcome to Vet Neurojar, the podcast dedicated to all things neurology. Today, we are diving deep into a common yet complex condition affecting our equine athletes, exertional rhabdomyolysis. We will explore what it is, why horses are so susceptible, and how we can manage and prevent it. Exertional rhabdomyolysis, often referred to as tying up, is a syndrome involving damage to skeletal muscle. This condition has different forms and triggers. To understand it, we must first delve into the mechanics of muscle contraction. Muscle contraction explained. Imagine a muscle fiber ready to contract. The process begins with an electrical signal, an action potential, traveling along the muscle cell membrane and into the T-tubules. These T-tubules are like tiny tunnels that allow the signal to reach deep inside the muscle fiber. Next, these electrical signals are detected by dihydropyridine receptors. These receptors interact with the sarcoplasmic reticulum, or SR, which is a storage site for calcium. The ryanodine receptors, specifically ryanodine receptor 1, or RYR1, are calcium release channels on the sarcoplasmic reticulum. When the dihydropyridine receptors interact with the ryanodine receptors, calcium is released from the sarcoplasmic reticulum into the muscle cell. This release of calcium is critical because it activates the contractile machinery of the muscle. Calcium binds to troponin, which then facilitates the interaction between actin and myosin, the proteins responsible for muscle contraction. Think of it as tiny bridges forming and pulling, causing the muscle to shorten and generate force. Relaxation, however, is just as important as contraction. For the muscle to relax, calcium must be removed from the muscle cell and pumped back into the sarcoplasmic reticulum by an enzyme called sarcoplasmic reticulum calcium adenosine triphosphatase, or SERCA. This process, along with the detachment of myosin from actin, requires energy in the form of adenosine triphosphate, or ADP. Now, here is where things can go wrong. Exertional rhabdomyolysis occurs when there is an excessive and uncontrolled rise in calcium within the muscle cell. This overload of calcium leads to the activation of enzymes that degrade muscle fibers, resulting in cellular damage and the release of muscle components into the bloodstream. This muscle damage initiates a cascade of events. Macrophages, the cleanup crew of the body, arrive to remove debris, and satellite cells, which are muscle stem cells, begin the process of regeneration. Complete repair of muscle fibers can take around 4 weeks. Clinical signs of exertional rhabdomyolysis. The signs of exertional rhabdomyolysis can vary. In mild cases, a horse might show stiffness during exercise or a decreased willingness to work. As the condition worsens, signs become more apparent. These include a short stride, shifting lameness, general stiffness, sweating, and reluctance to move forward. The muscles, particularly in the hindquarters, may feel firm to the touch, and the horse's respiratory and heart rates may be elevated. In severe cases, the horse may exhibit pawing or even become recumbent, unable to rise. Diagnosis of exertional rhabdomyolysis. Diagnosing exertional rhabdomyolysis involves assessing the levels of muscle enzymes in the blood. When muscle cells are damaged, they release enzymes such as creatine kinase, aspartate aminotransferase, and lactate dehydrogenase into the bloodstream. Elevated levels of these enzymes indicate muscle damage. Creatine kinase is particularly useful because its levels rise rapidly after muscle injury, peaking within 4 to 6 hours and returning to normal within 48 hours if there is no ongoing muscle damage. Aspartate aminotransferase is less specific because it is also present in other tissues, but it persists longer in the serum, making it useful for assessing the chronicity of the condition.
Treatment of acute rhabdomyolysis. When a horse is experiencing an acute episode of exertional rhabdomyolysis, immediate and appropriate treatment is critical. The first step is to stop exercise and provide supportive care. Hand walking is not recommended, as it can worsen muscle damage. If the episode occurs during a competition, it is best to treat the horse on site and avoid long-distance transport for at least 24 to 48 hours. Dehydration is a major concern, as myoglobin, a protein released from damaged muscle, can be toxic to the kidneys, especially when combined with dehydration and nonsteroidal anti-inflammatory drugs. Therefore, hydration status should be assessed and addressed immediately. Tranquilizers can provide relief from pain and anxiety. Acepromazine is a good choice for moderate pain in well-hydrated horses. Xylazine or ditomidine, combined with butorphanol, can provide more potent sedation and analgesia. Nonsteroidal anti-inflammatory drugs can be used in hydrated horses for additional pain relief. In cases of extreme pain, a constant rate infusion of ditomidine, lidocaine, or butorphanol may be necessary. Muscle relaxants like methocarbamol may also be beneficial. Dantrolene, which reduces calcium release from the sarcoplasmic reticulum, can help to reduce ongoing rhabdomyolysis. However, caution is advised when using dantrolene in horses with hyperkalemic periodic paralysis, as it can elevate serum potassium concentrations. Dantrolene should be administered with food to aid absorption. Fluid therapy is crucial, especially for horses with myoglobinuria. Intravenous fluids are optimal for moderate to severely dehydrated horses. Electrolyte imbalances are common with severe rhabdomyolysis, so serum electrolytes should be monitored and corrected as needed. Horses with exertional rhabdomyolysis are typically alkalotic, so bicarbonate therapy is usually not appropriate unless there is concurrent metabolic acidosis and myoglobinuria. Sporadic exertional rhabdomyolysis. Horses are more prone to exertional rhabdomyolysis than other species. This may be due to evolutionary adaptations for speed. Equine muscle has a large amount of calsequestrin, a protein that allows more calcium to be stored and released during contraction. Additionally, horses have a truncated sarcoplasmic gene, resulting in high circ activity and a robust fight or flight response, leading to enhanced calcium release. These adaptations enhance muscle performance, but also increase the risk of exceeding tolerable calcium concentrations, triggering rhabdomyolysis. Sporadic exertional rhabdomyolysis can be triggered by several factors, including exercise beyond the level of training, electrolyte imbalances, inadequate antioxidant intake, or underlying respiratory viral diseases. Overexertion is a common cause, particularly in horses that have not been adequately conditioned. Dietary imbalances, especially diets high in non-structural carbohydrates and low in forage, or deficiencies in electrolytes, selenium, or vitamin E, can also precipitate episodes. Management of sporadic exertional rhabdomyolysis involves rest, dietary adjustments, and gradual resumption of exercise. After an acute episode, rest with regular access to a paddock is recommended, along with weekly monitoring of creatine kinase activity. The diet should be assessed to ensure it is balanced and appropriate for the horse's level of exercise. Good quality hay and concentrates with moderate levels of soluble carbohydrates, fat, and fiber are suitable. A salt block or daily salt supplementation is necessary to provide adequate sodium chloride. Once creatine kinase levels return to normal and muscle fibers have regenerated, training can be gradually resumed, starting with short periods of exercise and gradually increasing the duration and intensity. Chronic exertional rhabdomyolysis. Some horses experience chronic exertional rhabdomyolysis, characterized by repeated episodes despite reasonable management. In these cases, an intrinsic abnormality in muscle function is suspected. Chronic exertional rhabdomyolysis includes conditions such as malignant hyperthermia and recurrent exertional rhabdomyolysis. Unlike sporadic exertional rhabdomyolysis, prolonged rest is not recommended for horses with chronic exertional rhabdomyolysis. Instead, they should be gradually returned to work as soon as they are pain-free and moving normally.
Recurrent exertional rhabdomyolysis. Recurrent exertional rhabdomyolysis is a chronic form of exertional rhabdomyolysis that affects a significant percentage of thoroughbreds and standardbreds. It is also likely to occur in other breeds such as Arabians, warmbloods, and quarter horses. Young Maras are more commonly affected, and a nervous temperament is often associated with this condition. High grain diets and lameness can also exacerbate recurrent exertional rhabdomyolysis in susceptible horses. Horses with recurrent exertional rhabdomyolysis may appear normal when unfit or in low-stress environments. However, when fit and in a race training environment, or when training for competitions, they intermittently develop muscle pain and stiffness. These signs usually appear within 30 minutes of starting exercise or after exercise ceases. A day or more of rest before exercise can increase the incidence of rhabdomyolysis. The underlying cause of recurrent exertional rhabdomyolysis is an abnormality in the regulation of intracellular calcium flux within skeletal muscle. Studies have shown that horses with recurrent exertional rhabdomyolysis have higher levels of ryanodine receptor 1, increased calsequestrin, enhanced pathways for beta-adrenergic stimulation of ryanodine receptor 1, and indicators of mitochondrial apoptosis. Excitement can trigger episodes of rhabdomyolysis in susceptible horses, leading to prolonged opening of ryanodine receptor 1, excessive calcium release, persistent muscle contracture, and mitochondrial degeneration. Genetic factors also play a role in recurrent exertional rhabdomyolysis, although a simple genetic basis has not been identified. Diagnosing recurrent exertional rhabdomyolysis involves assessing clinical signs, identifying risk factors, and measuring creatine kinase and aspartate aminotransferase levels after exercise. Muscle biopsies are usually nonspecific, but may be useful in recurrent or unmanageable cases to rule out other forms of exertional rhabdomyolysis. Management of recurrent exertional rhabdomyolysis. Managing recurrent exertional rhabdomyolysis requires a multifaceted approach, including environmental modifications, exercise management, dietary adjustments, and sometimes medication. Reducing stress in the horse's environment is crucial. This may involve changes to the barn setup, providing compatible equine companions, and maintaining a consistent daily routine. Daily turnout is highly beneficial for reducing anxiety and the likelihood of rhabdomyolysis. Unlike sporadic exertional rhabdomyolysis, rest is not recommended for horses with recurrent exertional rhabdomyolysis. Regular daily exercise is important to maintain muscle function and prevent episodes. Clinical judgment should be used, but often horses are returned to regular daily exercise when serum creatine kinase falls below about 3,000 units per liter. It is important to avoid forcing horses to maintain slower speeds and to incorporate interval training. A nutritionally balanced diet is essential. For thoroughbreds and standardbreds in training, providing enough calories in a palatable form is crucial. These horses may require more than 30 megacalories of digestible energy per day. Concentrates should contain 12 to 18% non-structural carbohydrates and 10 to 13% fat. High-fat, low non-structural carbohydrate diets may decrease muscle damage by reducing anxiety and excitability. Omega-3 fatty acids can also be beneficial. Medications such as dantrolene can help to decrease calcium release from the ryanodine receptor. Administering 1 to 2 milligrams per kilogram of dantrolene 60 minutes before exercise can mitigate the differences in gene expression between susceptible horses and control horses. Tranquilizers such as acipromazine may be used in horses prone to excitement. Some maras may benefit from estrus suppression using progesterone injections. Adjunct therapies such as massage and stretching may also be beneficial.
Malignant hyperthermia. Malignant hyperthermia is another cause of chronic exertional rhabdomyolysis. It is due to a dominant mutation in the skeletal muscle ryanodine receptor 1 gene. This mutation lowers the activation threshold of ryanodine receptor 1, resulting in excessive calcium release from the sarcoplasmic reticulum. Malignant hyperthermia affects less than 1% of quarter horses and paint horses. Clinical signs may be inapparent or intermittent. Rhabdomyolysis can be induced by exercise, stress, or anesthesia. Some horses may have both the malignant hyperthermia mutation and the glycogen synthase 1 gene mutation for polysaccharide storage myopathy, making clinical signs more severe. Horses with malignant hyperthermia may exhibit classic signs of exertional rhabdomyolysis and have a very elevated rectal temperature. Genetic testing is required for diagnosis. Muscle biopsies are often normal or show nonspecific signs of muscle degeneration. Dantrolene can be used to block excessive calcium leak, but its use may be limited by the unpredictable nature of episodes. In summary, exertional rhabdomyolysis is a common condition in horses with different causes and presentations. Whether it is sporadic, triggered by external factors, or chronic, stemming from intrinsic abnormalities, understanding the underlying mechanisms and implementing appropriate management strategies are key to maintaining the health and performance of our equine athletes. Remember that while sporadic cases of exertional rhabdomyolysis benefit from rest, horses with chronic exertional rhabdomyolysis require regular daily exercise. And always ensure that horses with myoglobinuria receive intravenous fluids to prevent renal damage. Thank you for joining us on Vet NeuroJar. Keep those minds inspired, hearts light, and tails wagging.